have a presentation today about treatment switch in HIV strategies. So starting first is switching, why we are actually switching treatment if it works. We're switching sometimes if, in case of virologic suppression, so it switch treatment which already works actually, and that will start with this first part of it. What is the reason to switch treatment? It is a many reason actually. Sometimes we'd like to simplify regimen, to reduce pill number, to reduce frequency, to start treatment. We're switching because of safety and tolerability of drugs. We're switching because of comorbidity of drug-food interaction, because of pregnancy or planned pregnancy, and sometimes because of costs. What you need to consider if a switch treatment is a stable switch? So consider the previous treatment history, the previous resistance in a case that some exist or they did some, and we look for adherence of patient for compliance. We're looking for drug-drug interaction or possible interaction. We're looking for some comorbidities and some other conditions. But its EACS guidelines say what are the strategies to switch in case of virologic suppression. It's, for example, it's documented toxicity or safety reason. It's a prevention of long-term toxicity, like in case with, for example, with tenofovir. To avoid serious drug-drug interaction, in case of planned pregnancy, especially in case of planned pregnancy, because if women are already pregnant, we know about it about week 12 or 14, it sometimes makes no sense to switch treatment more. And it's because of age and comorbidity, for example, and cardiovascular disease risk. It's simplification of treatment to reduce a pill number, of adjust to food restriction. Or it started some other regimens, like, for example, starting hepatitis C treatment in a patient with co-infection. That's it, we need to take account that it's like some principles that should be mentioned if we change treatment in virologic suppression. We look for completely history of viral load suppression, of tolerability use, of cumulative genotypic resistance. It is important to look which resistant patient already had in the past, because if we change in virologic suppressed patients, we have no possibility to make resistant tests at all, so we look for the history of that. If we change from protease inhibitors, we need at least 2 fully active drugs. For example, if we change for NNRTI, we looked for 2 fully active NRTIs. We're looking for remaining option, that the remaining option in the case that switching treatment doesn't work and that we could change again and we need change again, that we take this option in consideration. And we're looking for genetic barriers, and we'll switch the medication with the single drug with same genetic barriers. We look that it's no resistant to other new drugs. We're looking very carefully for the new drug-drug interactions because we change treatment. We're looking for the other medication or other food the patient take. If you change from tenofovir and not switching to TAF, so we look for HPV status because in that case we could have a flare of hepatitis B if we stop tenofovir treatment. Normally we order patient in to come again in approximately 4 weeks to check for virologic suppression and a possible toxicity. And it is not necessary to switch any treatment. We decide with it just old-fashioned and it's not so modern, but if it's work, it's not absolutely necessary to change so-called winning team because it works now. That is something a little bit new. They talked last time a lot about it, about dual therapy and so-called class pairing regimens that we look for only 2 drugs in the treatment. It's like dual therapy, like dolutegravir plus rilpivirine. This 3TC plus PI, for example, darunavir or atazanavir, and it's already proved treatment with dolutegravir 3TC. That's still not recommended by EACS, but probably it will be changed. And monotherapy is, should be very careful, because monotherapy, it's not that obviously work. And in some clinical trials, for example, monotherapy with darunavir was associated with virologic rebounds, but for some patients it's still an option for very stable switch and a patient who are not candidates for dual treatment regimens. But it's strategies that are not recommended by European AIDS Clinical Society. It's monotherapy with atazanavir, it's monotherapy with dolutegravir, triple NRTI combination, and specific 2-drug combination like 1 NRTI, 1 NNRTI, or 1 NRTI plus 1 PI, or for example, maraviroc plus raltegravir, or atazanavir plus raltegravir. And it's absolutely not recommended, it's stop treatment or make some prolonged treatment interruptions. So in 2 cases, it just look for switching to 3 drug regimens where that's usual, that's like traditional treatment with some contras and pros. The contras are sometimes we have a booster in this treatment, sometimes it's more expensive. The pros, patient preferred such regimens because there's, for example, single tablet regimens, and sometimes it's good because of comorbidities. One of the last clinical trials that was presented on the EACS conference this year is a study of switching to bictegravir FTC TAF from dolutegravir FTC TAF and tenofovir. You see the stable patient will be switched with HIV viral load below 50 for a long time and no previous integrase mutation known, and after 84 weeks you see that this trial show non-inferiority, that it's switching treatment on this new single tablet regimen show non-inferiority in compare to prolonged treatment with control arm with dolutegravir plus TAF. Is a switching to a dual regimen, to 2-drug regimens also work? It is, but we need a right to drug regimens. For example, in some cases, it's good to switch to dolutegravir rilpivirine or to dolutegravir plus 3TC or boosted PI, for example, to 3TC plus 3TC. And it's one of the last trials what presented is called Tango trial, the switching strategies to dolutegravir plus 3TC versus continuing regimen with TAF-based ART, stable switch with, again, with patients who are below 50 for more than 6 months, and either switch to dolutegravir 2-drug regimens or staying on TAF-based regimens, and also this trial show non-inferiority for this new 2-drug regimens in this stable switch option. I just showing a short clinical case just to know how it works with the switch and treatment. As a patient from our practice, it's 53 years old man with HIV and HCV. Here in the past used drugs, including heroin and cocaine, currently on a stable opioid substitution treatment, but probably because of cocaine abuse and other reasons have end-stage kidney disease and hemodialysis, and he has HIV since 2002. You see all these parameters. His initial CD4 count was low, and HCV genotype 3 with fibrosis stage 3 as well, and no hepatitis B. So we look for the new treatment for this patient. This is a short history of him. So they started all drugs that we have before. We also with DDC and nilfinavir, and he was switched to fosamprenavir plus abacavir, 3TC. And after dialysis, it was typical actually for Frankfurt because of my former chief here changed a lot of the dual PI treatment regimens like lopinavir, saquinavir. We do it a lot of in the past in Frankfurt, and it was good for dialysis patient because you have now NNRTI, and then this patient was switched to monotherapy to darunavir. And so we are looking now for HCV treatment actually for this patient. So what we take in account, we have a patient on the hemodialysis, we have a patient with very impaired renal function, and we have a problem with all NRTI, NTI, so we need dose adjustment in this case, or it's even not recommended, most of them, for such glomerular filtration rate. So NNRTI and PI would be okay for this patient, but this patient need to be treated for hepatitis C. And we look for a recommendation for genotype 3, for example. It's two possibilities actually now that we use in Germany. It's either glycapravir, pibrentasvir, or Sofvel for 8 or 12 weeks for genotype 3 patient. And this is a recommendation actually for Hep C treatment if patients have chronic kidney disease in stage 5 or 4 or 5. So we could not give sofosbuvir, so it's recommended only PI-based regimen, but because of genotype 3, we could only give him actually this combination with glycapravir, pibrentasvir. And then we switch to drug-drug interaction, and we know that many or all PIs are not recommended actually to use with PIs for hepatitis C treatment, and then excluding PI containing regimen, and also excluding NRTI because of end-stage kidney disease, and it's still not so many options actually, and we decided for this patient for treatment with dolutegravir plus rilpivirine. In that case, it's constructed case just to show how it works with a switching and stable treatment regimen, because the patient has no viral load, now is undetectable for HIV, and we could make Hep C treatment. What about switching, about new drugs in the switching virologic suppression? It's data from two clinical trials, at Atlas and Flare trial, and it's more interesting for us in this case because it's because of stable switch. In the Atlas trial, it's new drugs, it's injectable integrase inhibitor cabotegravir plus rilpivirine versus daily oral free drug regimen continuum, and yes, you see also in this trial was a stable switch from a patient with undetectable viral load. There was, after loading dose of cabotegravir, was switched to the injection of cabotegravir plus rilpivirine. And you see this, both this trial, it was also another one is naive trial, and both of them show a non-inferiority, so that this regimen works as well. So then move to second part is switching after virologic failure. What we need to take into account if we're switching patient with failure on RT. It is two strategies that recommended by EACS. If HIV viral load between 50 and 500 copies per mil, the first we check for adherence of patient. We just ask patient if we really take the medication. We check for probably for viral load in few weeks again, and sometimes the genotypic testing are not possible because the viral load is very low. It's not possible to make a genotypic resistance test, and the change in that case in treatment based on the past treatment and resistant history. And if the patient has confirmed viral load above 500 copies per mil, we need to change as soon as possible because it's higher risk for patient to acquire more resistance, and the change will be dependent on intestinal resistance test, of course. If no resistance, we will look for a check again for adherence, for compliance of the patient. Probably we have possibility to make a therapy drug monitoring to make a look for the plasma concentration of the drugs. And if resistant mutation found, we switching accordingly with resistance test with a goal, the new regimen achieve below 50 copies per mil in 6 months. That it's strategy recommended by the European Clinical Society, so it used at least 2 better free active drugs in new regimens based on the resistant mutation in this current test or in the past. Any regimen should use at least 1 fully active boosted PIs plus 1 drug from 1 class that's not used before, so it's not recycling before, not recycling like integrase inhibitor, for example, or some other classes like CCR5 antagonist, for example. And alternatively, a regimen could be constructed with dolutegravir plus 2 NRTIs, which at least 1 NRTI is fully active. It should be very careful if a change treatment with less than 2 active drugs available, but based on resistant test, and treatment interruption of course not recommended, and I mentioned before, and consider that we leave, for example, 3TC or FTC, even in a case where they have M184 V mutation or E mutation, for example, just to make this selection to reduce viral fitness. If many other options are available, we look for drug-drug interaction, risk of toxicity, and other parameters. That it's DHHS guidelines will recommend in a case that you have a first-line regimen failure with boosted PIs, for example, you look for adherence and for toxicity. If it is a failure with NRTI, it's recommended to switch to boosted PI plus NRTIs or plus integrase inhibitors or plus dolutegravir plus NRTI if fully active. And if you have failure with integrase inhibitor, we'll switch to boosted PI plus 2 NRTIs or plus active integrase inhibitor or dolutegravir, probably in a higher dosage. And the second line treatment, we are first looking if protease inhibitor are still working, and if it still works, we change to treatment with PIs plus NRTIs. Otherwise, we look for some active drugs we still could use in this situation, but sometimes it's only salvage options with not really active drugs, not really active drugs in the treatment at all. This is another case, a patient who was treated till 2010 with tenofovir FTC efavirenz and was non-compliant, and because it was non-compliant and doctors afraid of some resistance, was switched to PI containing treatment regimen with FTC tenofovir and atazanavir, and after that, it was undetectable, and because of simplification, was changed to 1 tablet regimen with integrase inhibitor with elvitegravir boosted with cobicistat plus tenofovir plus FTC, and after that, patient have virologic failure with not very high, but viral load between 400 and 600, and it works with resistance tests. It's not observed that it works if you have 450 copies, but it works in that case. And you see the patient have a lot of mutation already from his old history, probably have mutation for 3TC, FTC, of course, and he has some NNRTI mutations like K103N and already, but it's very bad in this case as mutation for integrase inhibitor, so it will be difficult to reuse this drug classes. And after on this algorithms, if we consider this resistance test and we see we have boosted PIs that are still active, we could change treatment for the boosted PIs plus 2 NNRTIs and the change treatment for TAF plus FTC plus boosted darunavir, and it works. Is something new that some new agents coming, especially for the patients with virologic failure with multi-drug resistant virus with so-called salvage situation. And this is just 2 trials, 2 new drugs, on new candidate to be drug. That's not like, one is already approved as an ibalizumab, that it's antibody to CD4 receptors to block HIV entry. For the patient, this trial show the patient is heavily pre-treated with more than 1,000 copies per mil and resistant to many classes. And it's a drug that could be given only intravenously, and you see even this, and you see it, and excuse me, just come back. And this medication, this ibalizumab, was given as loading dose first to the continuum drug regimens that doesn't work actually, and then after day 14 switched to optimized backbone plus every 21 days intravenous, every 2 weeks intravenous ibalizumab. And you see even in this group of heavy pre-treated patients with multi-drug resistant viruses, you see the 43% after week 24 was below detection, below 50 copies per mil, and 50% of patients below 200 copies. And it's good results actually for this group of patients who could not be treated with other medication at all. And it's actually a medication that's approved by FDA and recommended if you see only the patient that with multi-class resistant viruses who lack sufficient treatment option with other suppressed regimens. And another new compound is this HIV attachment inhibitor for stemzavir, was presented with the data of BRIGHT trial. And you see also here heavily pretreated patient with multi-resistant viruses on to randomized, non-randomized cohort, and non-randomized cohort means it's absolutely no remaining ART option for this patient, and with all this was treated with for stemzavir, and you see even in the group of the patient that absolutely have no other option, even in this group, you see about 37, about 40% of patients are undetectable at week 96. Thank you very much for your attention, and thank you for the questions.